Hi, and welcome to today's presentation. My name is Mike McNamara, and I work in the Cardiovascular Health Program and manage both the Cardiac and the Stroke Recognition Awards. Today's presentation is going to be about STEMI and how it ties into the Recognition Award, and hopefully it'll be able to give you some ideas about some quality improvement projects. The presenter today is Todd Moore. He's a physician assistant working at St. James Healthcare in Butte. He's worked in the emergency department for over 20 years, and for the last year provides full-time healthcare education as a quality program coordinator. He became an EMT and worked on an ambulance at age 16. He joined the U.S. Air Force at age 17 as a fire protection specialist. He completed the Air Force Physician Assistant program over 25 years ago. Todd is the medical director for several volunteer EMS services in Southwest Montana and believes that is his way to give something back to his roots. So Todd, thanks a lot and take it away.
Thank you, Mike. And I truly appreciate the opportunity to be able to bring this information to you today. And again, I'm truly blessed in my career and glad to have the opportunity to give back to everybody else. So my references for today are listed here, and I'm the first to admit that I'm not the smartest guy in the room. These guys have done all the work, they've done all the research. What I do is try to package it in an understandable way to help benefit your clinical practice. I'll outline some time savers, things that you can do in your practice that can help save time and save muscle and save tissue. So this is where we live, and we are truly blessed to have what we do available to us every day, and this just beautiful country, the big sky country that we live in. This is what a lot of people might think when they think of Montana medicine, but this truly is what we provide. We are cutting edge. We've got some amazing people out there that provide some quality and cutting edge medical care to our communities. One thing to remember, though, is we are held to the same standard of care, whether the patient's in Los Angeles or Butte or in New York City. They are entitled to, and the expectation is they get the same standard of care as anywhere else. So when we're looking at cardiovascular care, I just want to kind of go over some of the rules. And what we rely on is the American Heart Association's guidelines. I don't want to drown you in data, but I do want you to understand the state does keep a tally on our numbers. And with that in mind, it's for our benefit. It can identify ways that we can improve our patient outcomes and our patient care. So I'm not going to go over every one of these, but there are some that I want to highlight that I think are important and can tell quite a story for us. So there were 269 patients, and all of these are over the 12 critical access hospitals. And so these are our chest pain patients that they had looked at, and 75% of them had arrived to our critical access hospital emergency departments by private vehicle. So I think that's an opportunity that we can put out some public awareness and education to ensure that they're calling the ambulance so they can get treatment sooner. And I'm going to point out a few key factors in our EMS folks that can really help our patients. It looks like here that only 26%, 16 patients received a 12 lead EKG from EMS. And 99% or 265 of our patients received an EKG in the emergency department in our critical access hospitals. Our door to EKG time, the average was 16 minutes, and we're going to talk about trying to improve that to less than 10 minutes. Here are only 52% of our patients in critical access EDs got an EKG in less than 10 minutes. This is outstanding here. 98% received an aspirin on arrival. And we're going to talk about the importance of that. 87% had a cardiology consult. Only 33, or a third of those eligible, got thrombolytics. And we'll talk more about that as well. Our door to needle time, less than 30 minutes, only 42% of the time was that met. And then our door in, door out goal, if we're going to transfer our patients out, which it looked like the majority have or are transferred out, was less than 2% of the time we met that recommendation of less than 45 minutes. Again, we transfer almost 97% of our patients. Our door to needle time, or giving a thrombolytic, was 48 minutes, and we need to get that time down. And then our door in, door out, the mean or the average was over 196 minutes. These are the modes of transport. And again, this is just what's available to you, what the weather conditions are, what the transport burden is, who's available for you. There's a lot of times when I work in the ER at Holy Rosary when ground isn't available, or they might have to come from another community. And a lot of times our hands are tied and there's not a lot we can do about that. But having systems in place, backups available, is huge in trying to prevent that. This is data from the EMS annual report, and I'll just go through this briefly. A lot of us are intimately involved in our EMS care with our EMS brothers and sisters. We're medical directors for them. We receive patients from them. And this is looking at their call volume. So they responded or transported 2,500 patients for chest pain and STEMI last year. Our on-scene time for our EMS providers should be less than 15 minutes. And they only met that about half the time. Only about half the time are they getting a 12 lead on scene. And they're documenting suspected STEMI where they do have ST changes, or their clinical impression is that this is acute myocardial infarction or a heart attack. The call to door time, the expectation for them from the time they're banged out to go to a call to getting to our door at the critical access hospital, is less than 50%. And then their aspirin administration, ours was pretty high. Theirs is only about 50%. So it's an opportunity that we can discuss with them the importance of giving that aspirin as soon as possible. And then their oxygen administration. So I'll start with the little case here, St. Elsewhere ER. This is squad 51. We have a 30-minute ETA with a 60-year-old male who comes in with 1 hour of chest pain. Vitals are as follows. And we have obtained an EKG, which shows ST segment elevation in leads 2, 3, AVF. And the EKG has been transmitted to you. Any questions or orders? So this is a pretty standard presentation. I've worked with our EMS brothers and sisters about giving this information to us, transmitting EKGs to the critical access hospital or the emergency department as soon as possible, giving us the heads up on this so that we can get the ball rolling for the patient care. So this is the EKG that we look at, and pretty clear cut what we've got here. I do want to do a little bit of refresher for those who aren't as comfortable in looking at EKGs. Remember that when we're looking at a problem with the plumbing system, all we can do with our 12 lead is look at the wiring system. So if we've got a problem with the plumbing system, that is going to reflect with an abnormality in the wiring system. And that's what translates onto the paper on our 12 lead EKG. I also think it's important that we oversee and ensure that we're getting proper 12 leads. I was surprised. At one point, I walked in the room to evaluate one of my chest pain patients, and the leads were completely in the wrong place. And so there was an opportunity for training with that individual. So make sure that you're overseeing that and you're not getting garbage in, garbage out. And what you're looking at is accurate information. So as a refresher, our extremity leads, actually, they need to go on the extremities, not on the torso, like a 3 lead or 4 lead or a 5 lead. And then make sure that our chest or precordial leads are in the correct space. So your technician or the nurse or whoever's obtaining your 12 lead actually needs to be palpating which intercostal space. So you come across the clavicle until you get to the manubrium, you drop down along the sternal border into the first intercostal space, then each intercostal space down on the right sternal border to the fourth intercostal space. And that is where V1 goes. Then you repeat the process on the left side, left sternal border, fourth intercostal space, and that's where V4 goes. We want to make sure that we're putting those in the correct position and we're not just playing pin the tail on the donkey. We also want to make sure that our extremity leads are on the extremity. Ideally, they'll be as distal as possible, but we know that that runs the risk of some artifact. So what I tell my people is start as distal as possible and then go proximal if you need to. Then we want to make sure that our placement is proper for our precordial leads. And by getting all of them in the correct place, we're getting a 360-degree view of that electrical conduction as it runs through the myocardium. So the top is what we're familiar with, our 12 lead. But when our EMS brothers and sisters obtain a 12 lead, it looks a little different. And so if they're transmitting these to you, it may get a little bit, it may take a bit to get used to what they're transmitting to us. So what do our views tell us? What I imagine is each of those electrodes that we're placing is like a little camera. It's taking a view of the electricity as it passes through the heart. My limb leads are looking in the frontal plane, and they are reflected on my 12 lead on the left side as 1, 2, 3, augmented V right, augmented V left, and augmented V foot. My chest leads are looking at the heart or the electrical conduction through the heart on the transverse plane. And those are on the right side of my 12 lead, V1 through V6. One thing to remember about our EKG paper is the little boxes can help us with measurements. So our tiny little red boxes are 1 millimeter. And for today's purposes, that's all we're going to focus on is that 1 millimeter. Now looking specifically at STEMI, it's all about the ST segment. So from the conclusion of our QRS complex until our T wave starts. And what's happening here is if there's an occlusion in a coronary artery, then everything downstream has diminished blood flow. With that diminished blood flow, if there's infarction of the myocardium, then as my signal goes through my bundle branches, my QRS depolarizes, the ventricles are contracting, there's a delay or there's a mismatch from when my T wave occurs or my ventricles are repolarizing. So what I do in my training is to visualize it for myself. This is my atria depolarizing, which is my P wave. Then there's a pause at the AV node. Then my QRS complex is my ventricles depolarizing, and my T wave is my ventricles repolarizing. So in that portion between the depolarization of the ventricles and the repolarization, that is where my ST segment elevation occurs due to the myocardial damage from the occluded artery. One thing I think that's important to note, because I've had a lot of people mention to me, that they do a 5 lead or a 3 lead to look to see if there's a STEMI. And we can't do that. What our 5 lead or 3 lead is looking at is in this Hertz range. So it is designed to only look at the QRS complex. Now I'll admit, I've seen some ST elevation on my 3 lead or my 5 lead. I think that's just bleeding over into this area because it's so huge. But it's not designed to look at the ST segment. That is down in this Hertz range. So for a complete view and the best view of my ST segments, I need to do a 12 lead. So I have this big picture here. To understand the ST segment, I need to measure it or find out where it starts at the J point or the junction point. That's where my ST segment starts. And I had done this wrong for quite some time. You cannot determine if your ST segment is elevated or depressed based on your PR interval or your PR segment. Your TP segment, so from your T wave to your next P wave, this is your isoelectric baseline. So this is where we should be measuring or comparing our ST segment to, not the PR, which can be affected by other things, some medications, pericarditis, etc. So in looking at this, what I want to do is draw a line through my TP back to where my J point is to see if my ST segment is elevated. And here we can see that's 1 box. And again, 1 box is 1 millimeter. So we'll practice this just a few slides just to get used to it. Here I can see on my TP segment, if I come backwards, my J point would be about in here. And again, I have about 1 box of elevation. Here, if I come through my TP segment and come back to my J point, there's no ST segment elevation here. And that may be misleading because this is an upstroking or sharp angle up on my T wave. If I come back from my TP segment here, my J point is actually down here. So there's no elevation at my ST segment. I'm sorry, I misspoke. My J point is here. This is part of my QRS complex. Here's my J point. Here's my J point here. Coming back from my TP, I can see that I've got depression of about 2 boxes. And here I have elevation. But how many millimeters? It looks like I've got 1 box, 2 box, 3 boxes. So 4 millimeters of ST segment elevation. This one can be a little confusing with this bundle branch block here. But if I come across from my TP, my J point is actually here. So I've got depression. Here's my TP here. And I've got a little bit of depression. And then one of our tombstone effects, I have elevation. So I hope that was helpful for you just to refresh on that. And again, how much is significant? What matters? Well, I like to say this is from the 3rd intergalactic definition, with all of these players all having a consensus on how much elevation is significant. And the consensus is greater than 1 millimeter in 2 contiguous leads, except for V2 and V3. It's a little more, and this has to do with males less than 40 are more likely to have a little bit of elevation there normally. Males greater than 40 have about 2 millimeters, females about 1.5. So the general rule is 1 millimeter, except for V2, V3, it's a little more. The other thing that I want to refresh on are reciprocal changes. So what our reciprocal changes are is they occur on the opposite side or site of the injury, opposite side of the heart. So if I'm looking with my 12 lead, again, it's looking all the way around the heart. if I'm looking and I see ST segment elevation because I've got infarction of the myocardium, if I'm looking at the opposite views or the opposite leads, I'm going to see ST depression because it's looking at the opposite side. The significance of that is if I've got ST segment elevation, I may question it and say, could that be elevation? Well, here I can see that I've got some elevation in V1, V2, and V3. And then I can measure that out at about 2.5 boxes in V1. If I'm not sure if that's elevation, and I see that I've got reciprocal changes, that is ST elevation because I've got a mirror image or an opposite side view that's confirming that I've got elevation here because I'm seeing the backside of it, which looks like depression. Also, just a quick refresher on STEMI localization. Again, our 12 lead is taking a picture around the entirety of the heart. So by looking at my 12 leads, I can determine where the infarction is and actually what coronary artery is involved. This is from osmosis.org. I watch a lot of their educational YouTubes, videos on YouTube, and I really like this slide. It puts it all together in a nutshell. So my inferior leads are 2, 3, and AVF, which is in this area along the right ventricle, and it's fed by the right coronary artery. So this is my inferior leads. AV, or lead 1, AVR, V5, and V6 are my lateral leads, so on this portion of the heart. And then V3 and V4 are my anterior leads, and V1 and V2 are my septal leads. This is just another view of this. This one's from the American Heart Association. And again, I know if I've got ST segment elevation in 2, 3, and AVF, it's affecting the inferior portion of my heart. And most of the time, it's fed by the right coronary artery. So again, back to our original scenario. Here's our 12 lead EKG. So knowing the rules, looking at the AHA guidelines, and these are hot off the press, the 2020 acute coronary syndrome guidelines. And we'll go through these step by step just for some key learning opportunities. So what is acute coronary syndrome? By definition, it's an acute myocardial infarction, or it could be unstable angina. That is the definition of acute coronary syndrome. So what we start with is, what are our symptoms that would tell us this could be acute coronary syndrome? If I have those symptoms, then I'm going to get a 12 lead EKG. If that 12 lead is positive for ST segment elevation myocardial infarction, then I'm going to treat it. I'm done. I just treat it. If it's negative for a STEMI, then I'm going to get a troponin. If my troponin is positive, or I should say elevated more accurately, then I'm going to initiate treatment for an NSTEMI because my EKG did not show a STEMI, but my trope is positive, so I have a non-ST segment elevation myocardial infarction. So we'll break this down box by box. What are our symptoms that would make us think that we need to get a 12 lead or this patient is having acute coronary syndrome? We are very, very familiar with these, and it's right out of the book. Chest pain, short of breath, radiation of pain, but also if they feel dizzy or lightheaded, or maybe it's that 80-year-old lady that just feels nauseous, or if they're sweating. And I'm going to talk more about that in a bit. This is Dr. Amal Mattu, and he's a professor at the Department of Emergency Medicine, University of Maryland, and one of my favorite people to follow on YouTube. And I'm proud that I got to meet him when he was presenting at a conference in Vegas a few years ago. So I think this is really, really important because I missed this on one of my patients. And unfortunately, she had a very bad outcome. And I will never miss this again. Also, atypical is typical. We've heard that from day one in our training. They're not going to tell you exactly verbatim out of the book what their symptoms should be. And then I found this interesting. Reflux is a common symptom for inferior MI and the most common diagnosed in court. And your HPI is the most important factor in predicting ACS. We're going to look at that a little closer. And then he had said that one EKG begets another in Genesis chapter. No, I'm just kidding. And then I added this one trope begets another. We should never be evaluating a chest pain patient with short-term symptoms and just dismissing them on one troponin or one EKG. We need to do serial EKGs and troponins because those can change over time. So looking at your history of present illness, there's 3 studies going all the way back to 1998 that show how important this is in telling us. Our patients are actually going to tell us if they're having acute coronary syndrome, if their pain radiates, if they're sweaty, if they're vomiting, if they have pain on exertion. Those are all highly predictive of acute coronary syndrome. So in our first box on our algorithm here, looking at our pre-hospital care, and they say right here that we should be doing 12 leads out in the field. Why would we want to do a 12 lead in the field? The biggest reason is to save time. Let's take a little scenario. EMS is called out at 9 a.m. for a chest pain. Takes them about 20 minutes to get there. They transport the patient about 15 minutes later. Takes them about 20 minutes to get, or 25 minutes to get to the emergency department. They get into the EKG or into the emergency department. It takes us about 15 minutes to get the EKG done. We notice that there's a STEMI, and so we're going to start preparing TNK to give this patient. And it takes about 10 minutes to get that ready. So from the time that we were called out to the time that we actually give the medicine, or our needle time, is an hour and a half. Now, if our EMTs are able to do a 12 lead on scene, 9 o'clock they get called out to respond to a chest pain, arrive on scene 20 minutes later. Within 5 minutes, they've got an EKG. They transmit that to the emergency department, and they call us and let us know that they sent it over. The provider takes a look at it, recognizes a STEMI, and tells the nurse or the pharmacist to start preparing the TNK. EMS is leaving the scene. They arrive to the emergency department 25 minutes later, and within 5 minutes, we're giving TNK, and we've saved that much muscle. And this is from the American Heart Association. All the way back 21 years ago, they were saying that our EMTs should be doing 12 leads in the field because it reduces time, it gets that information to us sooner, and it improves outcomes. So popping down to our next box on our algorithm, looking at all the things that we're going to be doing. If we've got a STEMI team, that's awesome. Doing our ABCs, getting them hooked up to oxygen, getting an IV in if the EMTs haven't done that yet, which most of them do that for us, which is great. Ordering a chest x-ray, getting our labs going, and then looking at some of our interventions. So one thing I want to mention in particular is how much oxygen are we going to put them on? And what the AHA has identified is if their SAT's less than 90. I remember the old days when I first started and when I was an EMT as well, that we slapped them on 15 liters non-rebreather mask, 100% flow. What we know better now is if we are hyperoxygenating our patients, if their SATs are 100% on our pulse ox, I don't know if it's 101% or 110%, we are causing harm. What's happening is if we hyperoxygenate them, we're causing vasoconstriction, and we certainly don't want to do that from an already occluded artery. So I'm going to titrate my patients up to 96, 97, 98%. I do not want to see them at 100% because I don't know if I'm hyperoxygenating them. Also with aspirin, our dosage is going to be 162 to 325 milligrams. We don't want to use enteric coated, and we want to have the patient chew it up so it absorbs faster. And I think one important thing, one thing that changed my practice is how long does it take for that aspirin to take effect before it's starting to make those platelets slippery, where if I'm the platelet that's grabbed onto this plaque that's disrupting in the coronary artery, from me grabbing my buddies to come help me form a clot around this disruption. How long does it take? It only takes 4 minutes for that aspirin to start taking effect. So do I want to do it as soon as I meet the patient, or do I want to wait an hour into the patient's course? I think it's pretty clear. Okay, looking at our EKG in our next step in the algorithm, what we want to do, and the goal is to get that EKG within 10 minutes. And I know we are going through the cardiac accreditation process, and it used to be the goal was door to EKG completed within 10 minutes. And that is changing. It's door or first medical contact to the provider interpreting the EKG. So we're really getting put to task to make sure that we're getting this done and the provider is actually interpreting it and deciding if that's a STEMI in less than 10 minutes. Now, going down the algorithm, I get my 12 lead and I look at it, and we can clearly see that I have an inferior wall ST segment elevation MI. In fact, I've even got reciprocal changes. So I know for sure that that is a STEMI. I do not pass go. I do not collect $200. I do not do anything. I start treating this patient. I don't need to get a troponin. I have the answer. We have a STEMI. We're going to start our adjunctive therapies, and then we need to open that vessel up. Now, if I don't have if I'm not in an area with a cath lab, or I can't have them in a cath lab in a timely fashion, I need to open that vessel up. So I am going to give TNKs. I don't even need to order a troponin. I already have the answer. It's a STEMI. You're done. Our adjunctive therapies, we'll do a heparin bolus, or sometimes if I'm out in a critical access hospital, I may just give them Lovenox and I'm done. And I do not delay reperfusion. You do not wait for a troponin to treat a STEMI because you already have the answer. Now, our reperfusion goals are door to needle less than 30 minutes from first medical contact. And that might be your EMT out in the field. That is first medical contact. Or when your nurse greets that door in the triage, or greets that patient in the triage room, that is first medical contact. So less than 30 minutes, we need to get our TNK going. Looking down the algorithm here, if our EKG does not show a STEMI, but we've got maybe some ST depression, or we've got some non-specific T wave inversion here, but I have no ST segment elevation here, then I'm gonna go down this portion of the algorithm. I'm gonna get a troponin. And if that is elevated, this is an NSTEMI, I'm gonna treat it as such. I'm gonna start my adjunctive therapies, my heparin, my nitroglycerin. Now, unfortunately, the preponderant, or I should say fortunately, most of the time, my EKG is going to be normal and my troponin is going to be normal. That's the majority of the cases. So now what do I do with them? So we want to risk stratify them. And the best way that I've found in my practice is to use the heart score. And I access it through MD Calc, free access. I've got the website saved as one of my favorites on my desktop. And we want to use it on patients with symptoms suggestive of acute coronary syndrome. If they've got a STEMI, it's non-applicable. This is what it looks like, and I can calculate my score. And I can either document heart score equals 0, 1, 2, 3, 4, whatever the score is, or I take screenshots of my calculation of this actually and put it in the patient chart in my note. So this is a completely normal person with no points. But let's say that the patient has moderately suspicious symptoms. They still have a normal EKG, but they're greater than 65 years old. They've got multiple risk factors. Their trope is normal, but their heart score is 5. In that case, I might consider admitting them because of those risk factors and their age to have further evaluation done and be ruled out. So how do I pull the trigger on giving TNKs? There's some authority out there. There's some backing for you to help do that. Dr. Waldo from the Mission Lifeline Project a few years ago had gone around the state and visited with all of the cardiologists in the area in the state, and they had come up with a consensus. And so these are the Mission Lifeline STEMI protocols, and these have just been updated, hot off the press. So these are there as a guide for you, as your backing, as your authority to go ahead and treat that patient. You don't have to call the cardiologist and wait 40 minutes for them to call you back. And then they want to see the EKG. So you have to transmit that and then wait to hear back. And you're wasting your patient's muscle. I'm not going to go through all of these box by box, but just show you quickly that this is available for you as a reference. Also a good reminder here, the second you see ST segment elevation MI, activate your transport, save time, get them on the phone, get them rolling out to you. And these are just different protocols that your nurse can document what their dosages have been given, what medications have been given, everything that's been done. And then this is our order set for the provider to give to the transporting units. All you have to do is check the boxes that's applicable for your patient. And I save these as a favorite on my desktop so that I can, if I'm seeing patients, I just open it up and I've got it at my fingertips ready to use. What I've also done is I use Epic primarily. If you have a electronic medical record system that you're using, is I pre-check everything that I can get done ahead of time. So it's less things that I have to think about in the heat of the moment. So we'll do a couple scenarios here, and then we'll get you back to your day. So this is a 63-year-old gentleman who had some chest pain at an outlying clinic. EMS got on scene. They had done a 12 lead, and this was their findings. So it's got a red flag for us already. And this is what the computer interpretation was. Now, I don't always trust the computer interpretation on my 12 leads. I looked at this and I'm like, this is hard to convince me that there's any elevation here, maybe a tiny bit, but I don't see a full millimeter. Now here, this is a little easier. I do have some depression in V2 and V3. Now, what I like about specifically the LifePaks and the Zols that they're using on the streets, Zolex and like the LifePak 20s, and I wish this did this on our EKG machines in the hospital, is it will actually tell us our J point deviation. If it's depressed, it'll be a negative. If it's a positive or above 0, that is elevation. And how much do we need again? 1 millimeter. So I've got a little more than 1 millimeter in 2, 3, and F. So those two contiguous leads, which are looking at the same area of the heart, confirming that I have an ST segment elevation MI. This is the EKG when it was obtained in the ER. And again, it's hard to imagine a lot of elevation there. We certainly have our depression here. But the patient underwent cath, and he indeed had some occlusion. They went into the right coronary artery. He had 50% blockage here and 30% here. And they went to the left side, and he had a totally occluded left circumflex. And this is after cath. Our ST segments are back to normal. This is another case where a 65-year-old gentleman had some low back pain, and EMS got an EKG on him. So at initial glance, I see a lot of artifact, and it's hard to decipher anything, any ST changes with all of this artifact. But this is how good the computers are. If I look here at my STJ point, either positive or negative, on lead 2, I've got greater than 1 millimeter of elevation, and in AVF, I've got greater than 1 millimeter of elevation here. Despite the artifact, it's able to pick that up. And then in V5 and V6, again, my low lateral leads, inferior leads, low lateral leads, I've got greater than 1 millimeter of elevation. So this is the EKG that we did in the ER. And here you can see we've got elevation. This is the cath report. This patient had occlusion of the large obtuse marginal branch, and then also 60% stenosis or blockage of the main body of the dominant circumflex. This is a case that I had, and this is data all the way back to 2012, looking at posterior infarctions. So just a little refresher on posterior infarctions. What we're going to see is in V1 and V2, and sometimes V3, we've got this horizontal ST segment depression, and we've got prominent upright T waves. Also, my R is going to be greater than my S. And the way I can confirm a posterior infarction is by looking at leads V7 through V9, and I'll show you how we do that. So this is a study, I call it the ROCO study, and Amamotu was a co-author in this. And what they showed, this paper, I would highly recommend that you review this. And I have a presentation that I do just on this paper on STEMI equivalence. This paper showed that posterior MIs, because it doesn't show ST segment elevation, are treated urgently rather than emergently. So we're losing myocardium. So here's the classic findings that we're going to see. And what I'll do is I'll just take my electrode cables off of V4, 5, and 6, and I'll put patches at the base of the scapula along the 5th intercostal space, reattach my electrodes, and reacquire. And now I have V7, V8, and V9 in this area here, and they're looking at the posterior section. Now, why do I have depression in V1, V2, and V3? Because these are reciprocal changes to my ST segment elevation. Now that I'm reacquiring a 12 lead with my camera angles looking in at that, I'm going to see ST segment elevation. This is a STEMI. This is a STEMI. So we're going to treat it like a STEMI. So this is a patient that I had. This patient, EMS had transmitted this EKG to me. I had heads up. I knew this patient was coming. So we're getting TNK ready. This patient comes into the ER, and I look on here and it says an abnormal EKG. But what I'm looking at are my numbers. And it wasn't sure if it was hypertrophy or ischemia, because all it sees here is depression. So when I look at this, V1, V2, V3, V4 are all significantly depressed. Those are reciprocal changes. So when you got to the ED, this is our first EKG confirming that depression. We moved our leads over, reacquired, and I've got 1 millimeter of ST segment elevation. This is a STEMI, and we squirted him. So he hit our door at 16:04. We reacquired this within a few minutes. We gave him TNK at 16:21. He had a little bit of reperfusion scariness, which is a good thing. That means the myocardium is getting blood again. And then this is right before the flight crew landed to take him to the PCI center, and everything's back to normal. Looks better than my EKG. And he got to the PCI center, and they had watched him for a while, and he started to re-infarct. That's why we don't keep him in the critical access hospital. That's why they go to the PCI center regardless, because I don't want them re-infarcting on me later. So he started to re-infarct later that night, probably about 5 or 6 hours later. They took him to the cath lab, severe triple vessel disease. He bumped his trope all the way up to 200. And despite that, he had normal LV function because we gave that TNK. So to summarize, we need to know the rules, be familiar with them, and follow them. And then also use our tools. Use our checklists that are available to us so that we don't miss anything. We need to work with our EMS brothers and sisters and make sure they're comfortable and trained and competent in getting a 12 lead to us as soon as possible. Time is muscle. And then we need to interpret that within 10 minutes. And if it's a STEMI, we treat it. We don't need a trope. pull the trigger and give them the TNK. Make sure that we're calling our transport services as soon as we think that they're going to need to be taken to a higher level of care. And practice. We want to be a well-oiled machine for our patients. Remember that we're held to the same standard of care as anywhere else. This is not us. This is who we are. And this is where we live. And I appreciate your time today. Do you have any questions for me, Mike?
No, I don't, Todd. That was awesome. You very thorough. Certainly, if anyone viewing this has any questions, they can shoot me an email, mmcnamara@mt.gov, and I can circle those back to you, Todd. But that was awesome.
Thank you.